بسم الله الحمد لله والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. Inshallah, in this lecture we will continue the pharmacology of the respiratory system. Today, inshallah, we will discuss the cough. First, cough, as you know, is a protective mechanism or protective reflex that removes foreign materials and secretions from the bronchi and bronchioles. It's produced by the cough reflex, which is integrated in the cough center, central nervous system, in the medulla. Most of the time, coughing is caused by respiratory tract infection, but can be also triggered by choking, إذا حاجة خنقتك, choking, or smoking. Smoking also can induce coughing. Air pollution also can stimulate or induce coughing. Asthma, as we know, the cough is one of the symptoms of that occur with asthma. Also, gastroesophageal reflux disease also can result in cough. Also, cough may be a symptom of serious disease, either minor disease such as sometimes with allergic rhinitis, or with minor disorders or minor elements, and sometimes cough is one of the symptoms that indicate a serious disease such as lung tumor, or even chronic bronchitis can also be associated with cough. Heart failure also can be associated with cough, and also coughing can arise as an adverse effect or side effect that result from drugs. And the famous drugs that associated with cough is the angiotensin converting enzyme inhibitors, which are used for treatment of hypertension. Angiotensin converting enzyme inhibitor is associated with dry cough. This is due to the accumulation of bradykinin, because bradykinin is broken down by the angiotensin converting enzyme. So this drug, when inhibiting this enzyme, angiotensin converting enzyme, will result in accumulation of bradykinin in the bronchioles, and this will lead to dry cough. So cough can arise as an adverse effect of medication. Now we'll talk about the drugs that used for treatment of cough, and first we'll start with the antitussive agents. Antitussive agents, as we mentioned before, are drugs that used to treat dry cough, not reproductive cough. Antitussive drugs act by an ill-defined, that means not well understood, mechanism of action, an ill-defined effect in the brain stem, depressing the cough center, so that usually the antitussive drugs are centrally acting, depressing the cough center in the medulla. So they associated with other adverse effects. So they are a target for a drug abuse. بنلقى الابيوز الاستخدام الخاطئ بتاع الانتيتصيف دراج ادويه السعال الجاف كثير جدا جدا. لانه for example we have الأوبيويدز او الأوبييتس اللي بيسموها برضه الأوبييتس such as الكوداين, heroin, morphine, benzidine, all of these having an antitussive effect. We'll see that in the coming slide. All opioids اللي هم narcotic analgesic have antitussive action even in low doses that less than the dose required for analgesia or for the pain relief. Those used as cough suppressant اللي هم الأوبيويد اللي بنستخدمهم as cough suppressant are members of group with minimal analgesic action and addictive properties, such as codeine and dextromethorphan, which is an synthetic opioid. Although they having minimum addictive properties, but we'll find that in practice they are commonly abused by drug abusers due to their euphoric effect, the euphoric effects that are associated with opioids. First, we have a codeine. codeine إذا ميثايل مورفين derivative للمورفين هو عبارة عن ميثايل مورفين. Also we have الهيدروكودون and الهيدرومورفون, all of these drugs having antitussive effects and used in practice incorporated in the cough antitussive syrups. They produce constipation as side effects because all of the opioids inhibit the GIT motility, the GIT movement, inhibiting through the enteric nervous system. They have an inhibitory effect upon that, leading to constipation and side effects of opioids. Also, they produce nausea and respiratory depression. نتيجة اللي هم عبارة عن CNS inhibitory drugs. So they, in case of overdose, they can produce respiratory depression. Also, we have dextromethorphan, which is a synthetic opioid. Synthetic opioid is active as an antitussive, but it is devoid, يعني ما فيه the analgesic and addictive liability. Also, nowadays we have a drug abuser for these drugs. Although in practice we find that dextromethorphan having addictive liability, but it's less constipating than codeine. Dextromethorphan is less constipating than codeine. Dextromethorphan is abbreviated by DM, so that any cough syrup, any antitussive agent, you find DM. DM is an abbreviation اختصار لدextromethorphan, means this cough syrup is antitussive that used for dry cough, استخدم للسعال الجاف. For example, we have Sidufan DM, Unifed DM, and Amylin DM, a lot of cough syrups that having DM, which is an abbreviation for dextromethorphan. Antitussive drugs should be avoided in case of chronic pulmonary infection, as they can cause undesirable thickening and retention of the sputum, because they centrally inhibit the cough center, so they will inhibit the expectoration that should be eased by the coughing. And in asthma, because of the risk of respiratory depression, because of opioids, as we know, especially in case of high dose, they are respiratory, they have an inhibitory effect on respiration because they belong to CNS inhibitory drugs. So to emphasize that an antitussive agent الأدوية السعال الجاف ما بنديها in case of chronic pulmonary infection because there is an increase in sputum production, and these drugs will tend to prevent the coughing, the cough reflex centrally, so they can inhibit the expectoration يعني removal elimination بتاع السبوتم by the cough، وده بخلي لي يحصل retention احتجاز and thickening of the sputum, and this can worsen the respiratory infection and respiratory depression. This is beside the inhibitory effect as we mentioned upon the respiratory center on the medulla. We have now, we'll talk about the expectorant drugs. As I mentioned, drugs that used for productive cough to facilitate expectoration and elimination of the sputum. They stimulate the production of watery, less viscous mucus, and they include two drugs, either guaifenesin or ammonium chloride. These two drugs having an expectorant effect. First, guaifenesin works by drawing drawing the water into bronchi. كونه يسحب لي الووتر في البرونكاي. This will lead to thin mucus and lubricate. بيعمل لي thinning للميوكس وبيعمل lubrication، يعمل اللي هو يسهل من الموفمنت بتاعته، الريموفال بتاعه lubrication on the airways، this leading to facilitating the removal of the mucus by coughing. Now we have also mucolytic drugs, mucolytic من الاسم بتاعها mucolytic lysis معناها will lead to break down تكسر لي الميوكس. Act directly on the mucus breaking down sticky thick secretion so they are more easily eliminated or removed. خليها انها بسهوله جدا ممكن بعد ذاك الجسم يتخلص منها عن طريق الكافينج. Mucolytic decreases the thickness of the respiratory tract secretion by altering the molecular composition of the mucus. We have two drugs that act as mucolytics that commonly used in practice. First, the bromhexine, which act to reduce the mucus viscosity, probably by breaking down the mucopolysaccharide fibers in the mucus. And we have also ambroxol, which is an also mucolytic agent that used in treatment of respiratory disorders that associated with visit and excessive mucus secretion. Ambroxol promotes mucus clearance, facilitates expectoration, and eases productive cough. This is ambroxol, and also we have bromhexine, and these two drugs are considered as mucolytics. Last, regarding the respiratory system, we will talk about the anti-tubercular drugs that used in treatment of tuberculosis. Regarding tuberculosis, WHO or the World Health Organization estimates that 1/3 of the world's population is infected with Mycobacterium tuberculosis. يعني 1/3 till about 33% of the population are infected with Mycobacterium tuberculosis. This is a large percentage. There is an progressive increase in multi-drug resistance of tuberculosis. And this is a challenging problem. Multi-drug resistant, the Mycobacterium treatment is very difficult, challenging, because there is a resistance even for the new drugs commonly that resisted by the Mycobacterium tuberculosis. So that we will find that these drugs are used in combination and for long-term therapy in order to decrease this multi-drug resistance. The tubercular bacilli can remain dormant but viable and capable of causing disease in a major therapeutic challenging. Also, this is one of the challenge that the bacilli, Mycobacterium, can remain dormant, sakna, but can infect and cause disease in infected person, and this is a challenging problem. Regarding treatment of tuberculosis, we have three basic concepts for the treatment. First, regimen must contain multiple drugs to which the organism is susceptible, or the organism is susceptible or sensitive, or that can be affected by these drugs. At least 3 or 4 drugs should be used together. The second concept that the drug must be taken regularly without interruption. And the second and the third concept that the drug must be continued for enough time, and usually this is about 9 to 12 months without interruption, as we mentioned. Combination therapy has the advantage that the advantage of reducing the risk of adverse effects, because when we use this drug in combination, we only use low doses of each. Low doses of, for example, rifampicin and ethambutol and streptomycin and pyrazinamide, low doses. But if we want to use only one drug, the only one drug should be used in higher dose, and the higher dose is associated with more adverse drug reaction, with more side effects. So the combination of the drug therapy enable to the use of drug in low doses, and this have the advantage in reducing the risk of adverse drug reaction, side effects. Especially that we know these drugs are used for long-term time, at least for 9 or 6 months. We have first-line drugs which are superior in efficacy. They are more efficacious than the second line drugs, and also have the advantage that they have less toxic, they have less side effects compared with the second line antitubercular drug. First line drugs include isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. While the second line drugs, which are more toxic, they have more adverse effects compared with the first line drugs, and they are less effective compared with the first line drugs. And they are indicated only when the Mycobacterium tuberculosis organism are resistant to the first line agent. ما بنستخدمها إلا إذا كان resistant في الفيرست line drugs. These second line drugs include cycloserine, ethionamide, aminosalicylic acid, rifabutin, quinolones, and carbamazepine, vancomycin, and thiacetazone. These are second line antitubercular drugs. This is the treatment, scheduled treatment for tuberculosis, and we have an intensive phase at least for 2 months. And in this intensive phase, we use four drugs: isoniazid, rifampicin, pyrazinamide, ethambutol. Then followed by continuation phase for 4 months, and we continue only with the first 2 drugs, isoniazid and rifampicin. Now we'll talk about these drugs in more details. First, isoniazid. It's active against susceptible bacteria only when they are undergoing cell division. So it is an bactericidal against active growing Mycobacterium tuberculosis, and bacteriostatic against non-replicating organisms. This isoniazid will kill the bacteria which are undergoing cell division, while it have bacteriostatic against non-replicating Mycobacterium tuberculosis. The mechanism of action of isoniazid is act by inhibiting the synthesis of mycolic acid, which are essential for components of the Mycobacterium cell wall. Mycolic acids are essential for the integrity of the bacterial cell wall, so that the bacteria can protect itself by this cell wall. By interfering with the synthesis of this mycolic acid, which is very important for the bacterial cell wall, we can lead to a defective cell wall, and this can lead to the death of the mycobacterium. Isoniazid is metabolized by acetylation it's acetylated to acetyl isoniazid by N-acetyl transferase enzyme, the enzymes that occur in the liver, bowel, and kidney. So isoniazid is a famous drug that metabolized by acetylation, and we mentioned when we talked about the pharmacokinetic, is acetylation is one of the conjugation reaction that result usually in inactivation of the drug. Regarding the metabolism of isoniazid, we have 2 genetic variations among the individuals. Some individuals are rapid acetylator that metabolize isoniazid rapidly, while the others are slower acetylator that slowly metabolize isoniazid. So this is called pharmacogenetic variation among the metabolism, among the pharmacokinetics of the isoniazid, and this will affect the pharmacotherapy, because rapid acetylator may involve higher doses compared with slower acetylator, and also the incidence, presence of the adverse effects are more common in slower acetylator compared with rapid acetylator. The adverse drug reaction of isoniazid include hepatitis, liver damage, and CNS and peripheral neuropathy. Isoniazid induce or promotes renal excretion of vitamin B6 by redoxin, resulting in relative deficiency of vitamin B6, and this will result in neuropathy. This is a pharmacogenetic variation so that which can affect the half-life time. We have here a half-life time about 50 to 100 minutes. This means that these individuals are rapid acetylator, and the others we have the half-life time is more increased in equal minimum or more than 20 minutes the half-life time compared with this one. So these are slower acetylators. Rifampicin. Rifampicin is a large lipid-soluble molecule that is bactericidal for both intracellular and extracellular organisms. Mycobacterium inside the cell and outside the cell can be killed by rifampicin because it's lipid soluble, so it can cross the lipid membrane bilayer and can affect and kill the microorganism inside the cells. The mechanism of action of rifampicin, it binds strongly to a subunit of bacterial DNA-dependent RNA polymerase, and therapy inhibits the RNA synthesis. It's a protein. Rifampicin is widely distributed through the body, and therapeutic levels are achieved in all body fluids, including the cerebrospinal fluids. It means that have large volume distribution, very rapidly distributed throughout the body fluids. Rifampicin can induce its own metabolism, so its half-life time can be reduced to 2 hours within a week of continued therapy. We mentioned that rifampicin is an enzyme inducer when we talk about the pharmacokinetics and the drugs that affect drug metabolism. We mentioned that enzyme inducer and the enzyme inhibitors. Rifampicin is known as enzyme inducer, which can induce its own metabolism. حتى الميتابوليزم بتاعه هو نفسه بيتأثر بالريفامبيسين, so the half life time within 1 week will be shortened, will be decreased due to rifampicin itself. Rifampicin can induce hepatic cytochrome B450 enzyme, leading to an increased metabolism of many drugs. These include oral contraceptives, and we mentioned this as an example before. We mentioned that oral contraceptive can be failed due to the co-administration with rifampicin in patients with tuberculosis. Also, rifampicin can stimulate and can increase the metabolism of warfarin, digoxin, quinidine, antiarrhythmic drug, and sulfonyl urease, antidiabetic drugs. Rifampicin imparts harmless red-orange color to the urine. This rifampicin will change the urine, the color of the urine to red-orange color, but this is harmless, cannot affect the patient. Also can impart this harmless red-orange color to the feces, saliva, sweat, tears, and even the contact lenses that worn by the patient. We have pyrazinamide. Pyrazinamide, its exact mechanism of action is unknown, although its target appears to be the mycobacterium, the mycobacterial fatty acid synthase that involved in the mycolic acid biosynthesis, which is, as we mentioned, which is very important for the cell wall integrity. So pyrazinamide may affect the mycobacterial cell wall by interfering with the fatty acid synthesis through this enzyme, fatty acid synthetase. The pyrazinamide half-life time of pyrazinamide is about 9 to 10 hours in patients with normal renal function. This will excreted primarily by renal glomerular filtration. The pyrazinamide mainly excreted through the glomerular filtration. Adverse drug reaction for pyrazinamide include hepatotoxicity, nausea, vomiting, anorexia, fever, and malaise. Pyrazinamide inhibits excretion of urate, and this can result in hyperuricemia and precipitation of gout attack in some patients. Streptomycin, also one of the first line anti-tubercular drug, has a bactericidal activity against Mycobacterium tuberculosis in vitro, but inactive against intracellular organisms because streptomycin is aminoglycoside, and the aminoglycoside antibiotics are polar, so that cannot cross the lipid membrane bilayer, so only distributed through the body, total body water, cannot enter into the intracellular fluids. The adverse drug reaction of streptomycin include ototoxicity and nephrotoxicity as all of the aminoglycoside antibiotics. Ototoxicity is severe when aminoglycosides are combined with other potentially ototoxic agents such as loop diuretics, furosemide, and some of the other antifungal drugs such as amphotericin B also can increase the nephrotoxicity of the aminoglycosides such as streptomycin. We have ethambutol, also one of the first line anti-tubercular drugs. It acts by inhibiting arabinosyl transferase, the enzyme that involved in the cell wall biosynthesis, also can affect the bacterial cell wall synthesis. The adverse effects of the ethambutol include retrobular neuritis. Retrobular neuritis is an inflammation of the optic nerve behind the eye ball, and this can affecting the visual activity and lead to red-green color discrimination. عدم تمييز بين the red and green colors. Also, ethambutol can cause mild GIT intolerance, allergic reaction, fever, dizziness, and mental confusion. Also, ethambutol can lead to hyperuricemia. Hyperuricemia is associated with ethambutol use due to the decreased renal excretion of urate because it can competitively antagonize urate excretion, so it leads to hyperuricemia. We have para-amino salicylic acid. This is one of the second line anti-tubercular drugs. It's structural analog to para-amino benzoic acid, which is an essential component that used by bacteria in the folic acid synthesis. It's folate synthesis, so that para-amino salicylic acid is a folate synthesis antagonist that interfere with the incorporation of para-amino benzoic acid into the folic acid. بكتيريا بدل ما تتناول برا امينو بنزويك اسيد هتقوم تتناول جزيء مولكيول بتاع برا امينو ساليسيليك اسيد. This lead to synthesis of a compound not tetrahydrofolate, so this can inhibit the synthesis of the folic acid, and you know that the folate coenzymes are very important for the bacterial cell division. Para-amino salicylic acid is primarily metabolized by the hepatic acetylation like isoniazid. When combined with isoniazid, so that para-amino salicylic acid can function as alternative substrate and block the hepatic acetylation of isoniazid, thereby increasing its level, means the increased levels of isoniazid. Para-amino salicylic acid, both acetylated or unaltered drug, not acetylated drug, are rapidly excreted in the urine. So low rapid elimination. The adverse drug reaction of para-amino salicylic acid, GIT intolerance, leading to GIT symptoms, nausea, vomiting, maybe diarrhea, maybe abdominal cramp, abdominal pain, and lupus-like reaction. This is lupus-like reaction, like this reaction. We have ethionamide, which and second line anti-tubercular drug. It's a bacteriostatic anti-tubercular agent. It acts by inhibiting oxygen-dependent mycolic acid synthesis, so directly affect the bacterial cell wall synthesis. It's well absorbed following oral administration and then rapidly and widely distributed to the all body tissues and fluids including cerebrospinal fluid. This is the pharmacokinetics of isoniazid. It's metabolized extensively to dihydropyridine metabolites. Isoniazid, the adverse drug reaction include GIT disturbances, nausea, vomiting, abdominal pain, cramps, and CNS adverse effects, neurological side effects such as confusion, peripheral neuropathy, psychosis, and seizures. I think that is enough regarding antitubercular drug and even regarding the pharmacology of the respiratory system. Thank you, inshallah, and you will listen to me, inshallah, in the coming lecture. Assalamu alaikum wa rahmatullah wa barakatuh.